So as we pediatricians like to believe that safe motherhood is truly validated if the journey of the baby right from prenatal to postnatal is smooth and free of any adverse events. And this is exactly what we are going to discuss to complete the third dimension of this multi-dimensional conference, which spanned and covered and addressed issues of adolescence, pregnancy, and now let's just embark on the journey of baby. So with this brief introduction, it's my honor to welcome all delegates, esteemed dignitaries, and renowned speakers who've been able to give their valuable time for us. And my heartfelt gratitude to Dr. Jayalal sir and Dr. Jayesh Lili sir. I think they will join in some time for their beautiful vision at awakening India to safe motherhood. And my felicitations to Dr. Dilip Kumar Datta sir and his team for organizing such a beautiful, brilliant conference. And I would be failing in my duty if I do not recognize or acknowledge the tireless efforts made by Dr. Erika Patel, who did not leave any stone unturned to make this conference an academic treat. My best wishes to you for your endeavor, and I would like to now invite Dr. Erika Patel for IMA flag and IMA salutation.
Thank you, Dr. Juhi. I will now say the IMA prayer, do not required to repeat. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Flag salutation. We, the members of the Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it and realizing our responsibilities as the accredited members of this national organization. We swear we will dedicate everything in our powers to see it fly high in the Committee of Nations. Jai Hind, long live IMA. I take this opportunity to welcome one and all to this day 5 of this week-long conference. Today, we are going to talk about, I would just quickly give a brief about what we did. We started with the adolescent women's health. We did about preconception counseling. We took care of what all we can do to make the pregnancy safe. Yesterday, we had an excellent session about postpartum health of the woman, and today it is all about the baby and the neonatal journey and the journey of the baby from antenatal to the postnatal period. Over to you, Dr. Juhi. Without taking up much time, let's start the conference.
Exactly as you said, that let's not waste much time. So before we have Mrs. Preeta Reddy delivering her words of wisdom, let me invite the two pillars of the event today, Dr. Gargi Patel and Dr. Chalapati sir. I would like to share screen too. So Dr. Gargi Patel, madam, she is a gold medalist in MD Pediatrics, head of unit and professor in pediatrics at BJ Medical College Civil Hospital. She's a co-chairperson in National IMA Women Doctors Wing for this year, a national vice president of IMA headquarters 2021-22, and also a member of specialty of board of NBE. She's authored at least 3 books and has 15 publications to her credit. A very warm welcome, ma'am. Next is Dr. M. Venkatachalapati sir. Sir is the medical director and consultant at the Pati Hospital, Chikbalapur. He is the present president of Karnataka IMA branch 21, and he's a founder vice president of IAP Karnataka state branch in 2015. Sir is a nominated member of Karnataka Medical Council. A very, very warm welcome to both of you.
Thank you.
Now I would like to invite Dr. Gargi ma'am to invite Miss Preeta Reddy ma'am to deliver her words of wisdom.
Thank you, Dr. Jui, for your kind and generous introduction. I'm audible, ma'am?
Yes, ma'am.
Okay. First off, good evening to all. First of all, I'm very thankful to organizing team for giving me this opportunity. And I'm also thankful to our chief patron and visionary leader of the Indian Medical Association and World Medical Association, Dr. Ketan Desai, sir. Sir is a stalwart in our field. It is under his guidance and leadership that this organization has progressed and received accolades for their work. Sir's leadership qualities are truly exemplary, and we are honored that he has chosen to grace this occasion with his presence. Thank you. I am very thankful to our national president, IMA President Dr. J.A. Jailal, sir, HSC Dr. Jayesh Lile, sir, Dr. Anil Goyal, sir, Dr. Dilip Kumar Datta, sir. Also, under their able leadership and guidance, we are able to carry the IMA, the torch of the forward. I am very thankful to Dr. Vinay Agrawal, sir, for his presence. How can I forget to thank our young, dynamic, energetic Dr. Erika Patel? Without her sincere, constant, and tired efforts, with a little Arjun, this program is not possible. As already Dr. Jui mentioned, today is the 5th day of the webinar of the Safe Motherhood Week. Motherhood is indeed an epitome of love and sacrifice. Motherhood brings with its responsibility and changes. Balancing motherhood with a professional success. Balancing motherhood with a professional success is a tough job. And the perfect example of this, achieving this balance, is today's our esteemed guest, Mrs. Preeta Reddy ma'am. Ma'am is a vice chairperson of the executive of the Apollo Hospital Group. Ma'am has been the instrumental in the widespread success and the reputation of the Apollo Hospital, both in India and around the world also. With her penchant for the perfection, her managerial skill, she has uplifted the Apollo Hospital to the highest level, always ensuring the best treatment and care to the patient of the Apollo Hospital also. About the formal introduction of the ma'am, she is a master degree in public administration and conferred degree of Doctor of Science by the Tamil Nadu Dr. MGR Medical University in recognition of her outstanding work in the field of healthcare. She is a founding member of the Quality Council of India and played a key role in introducing the NABH accreditation with the Government of India. She is the president of the Net Health, that is the Healthcare Federation of India in 2020 to 21. She is an independent member, director of boards like Larsen and Toubro Limited. She has received so many awards, but few of them are. She is awarded as the Economics Times Business Woman of the Year Award 2021, Healthcare Personality of the Year Award by FICCI, NHRD and People CEO Awards, Women Leadership by the National HRD Network, leading several social projects like Sachi, that is a Save a Child's Heart initiative. That's very good. As a pediatrician, I know it's a very good initiative by ma'am. Thank you, ma'am, for the pediatrics point of view. I am telling you, for she is Sachi project is for the underprivileged children along with the congenital disease. And her able leadership, now the Apollo Hospital is robust around more than 70 hospitals, more than 4,000 pharmacy, and the 70 to 50 primary care clinics. After the oversimplified introduction, now give the very, very oversimplified introduction of the ma'am. Now invite Ms. Preeta Reddy ma'am for her inspiring words. Thank you, ma'am. Over to me.
Thank you, Dr. Patel, and all the members of IMA. To me, it's always an honor to speak to doctors and be part of any function, any event which has clinicians on board. And I'm saying that because, our doctors have just been phenomenal. Indian doctors are literally second to none globally, recognized globally. And we all know that if you walk into some of the best centers anywhere in the world, there will be the Indian doctors who are really holding our flag high, looking after patients and working tirelessly. Same thing in any of our research institutions anywhere in the world. Having said that, we know and we say that the doctors are miracle workers. We've seen during COVID how much our clinicians have literally been frontline warriors, have sacrificed so much, their personal lives, their families, to just serve our nation, serve the people of our nation. And I think that that's been truly, truly heartwarming and amazing. So to all of you doctors on this call, thank you so much for being part of this wonderful country. We're so proud of all of you. So thank you for that. In the same breath, when I talk about, doctors being miracle workers, mothers are miracle workers. They're miracle doers. They carry a fetus for 9 months and they literally give their life through the placenta. And a mother really works miracles every minute, every second, because as the child grows, as the fetus grows, the whole thought is to, let it be safe for the fetus. Let me have a beautiful baby. Let me deliver a healthy, happy, wonderful child. So what happens is literally these miracle workers or mothers don't really think about themselves. And to me, that is the key. That is the core. It's worrying that even today, India accounts for 15% of total maternal deaths worldwide. And to me, that's like a huge responsibility. It's a responsibility that, clinicians and doctors and all of you have to see ways and means to just create awareness. Because I think everything else is there. The government has put in so much of effort. There are wonderful facilities available both in the public sector and in the private sector. But what I see and I hear and I understand is that there's a huge lack of awareness. So safety really comes from awareness. Unless you know that this is the right thing and this is, not possibly the right thing to do, unless you're cognizant of what you have to do, 5, 6 steps of being absolutely safe, you're not going to really be able to handle the outcomes. And I think to me, that is really what safe motherhood is all about, is that the mothers, the expectant mothers, have to really be aware of the kind of things they need to do. And they need to be able to talk to the clinicians, go to the right centers for safe deliveries, and look after their health also. And I would strongly urge everyone to really look at that. Look at institutional deliveries, look at safe deliveries, encourage safe deliveries, because I think that is very important. Today, as a country, we're faced with 2 kinds of battles. We're today faced with a fear and a battle over the COVID crisis. And we also have to battle with just primary requirements, whether it's safe delivery, safe motherhood, the battle against NCDs, which we are all faced with. And how do we provide timely and the right access, not just in the urban towns, but all over the country, in distant locations, in remote locations. We need to find a way and a norm to see that if it's an expectant mother, whether she's in the most comfortable urban location, urban surrounding, or if she's in the remotest location and rural surrounding, can we find answers to all this? And the debate is about how do we ask these questions and find these answers. Just spinning back to the COVID crisis, because it's, uppermost in all our minds, the rate of pregnancy, I understand, has gone up, and it might have been for multiple reasons. So, we've actually seen a 0.12% increase in expectant mothers. And this, in a way, is a good thing, because then, people are then not afraid to have children and to deliver children. But having said that, how can we safeguard, just the future of these expectant mothers through the 9 months and then of the child post-delivery? So during the 9 months, we are hearing that number one is that vaccination is absolutely safe. And the more and more we hear about it, the more and more we research it, we're hearing that, it actually is recommended for safe motherhood to go ahead and be able to vaccinate yourself. If it's a lactating mother, again, that has been encouraged, that, we really should encourage lactating mothers to vaccinate themselves, and there is no fear of anything happening, to the child or to the young baby. So I'm hoping that, the obstetricians and the pediatricians will agree on this topic, but because this is what global data is showing, that vaccination becomes absolutely required in this situation. So I think a global pandemic, global questions, global answers are required, with the best in class of people working together, with the researchers, people from these institutions, and coming out with these answers. So then that leads me to the second point, that once we know and this kind of knowledge is there and is available, are we communicating it to everyone? And I think it's each one's job, whether it's the media, or whether it's social media, whether it's print or, visual media, we need to really communicate this fact that, it is required, and expectant mothers or mothers who have just delivered newborns have to think, and they have to look at vaccinations. And this would be extremely important. Now, the pre-COVID time, what are we looking at? Pre-COVID, we said that we really have to see that the mothers have the best possible nutrition, and we have to ensure that, again, the urban population or the economically safer people have access to good nutrition. They have data on good nutrition, but I don't know if that is enough. I think every mother, it's her right to be able to get the best possible nutrition. And for that, again, I think communication is the key, because I am sure that there are ways and means for mothers to get the right nutrition as and when required. So I think nutrition, again, becomes extremely important for expectant mothers. Post-delivery also, I think they need to be told and educated on just the safety of the child, because multiple times, young mothers or slightly older moms, they don't seem to understand that, there are multiple things which need to be done for the safety of the child. And there again, I think the communication is important. Sometimes it should actually be mandated, because I know for sure that most public health centers have everything which is there, which is required for a mother, for her safe delivery, and for the care of the child and the newborn afterwards. I think they need to be told that they should be able to access this. And some states do very well, and some states, I think, need to do much better. And this, again, will happen if IMA can come together and really be able to communicate this, and in a way, gently mandate or gently push the fact that as important today as vaccination is, I think good nutrition, good Sanitation again becomes important, because we're hearing and we're learning that on one side we have highly sophisticated healthcare available, and on the other side we don't have good, adequate sanitation. Sometimes even good, clean drinking water is hard to get. But I'm sure there's an answer for it, because there's so many agencies which are really looking at water management, providing good, clean drinking water. So we really need to look at that. And as we ensure the safety of these mothers on multiple fronts, I would like to say that once a child is born, the environment and the security of the child is important. And sometimes we see that, there's some accidents which should never ever have happened with the child. So the mothers need to be told and need to be aware that at least for the next, so many years of a child's life, and it's a maternal instinct to actually protect the child. And if we find that, the right things are not happening, it's not because of lack of basic instinct, it's lack of just basic education and knowledge. And I think that is a problem which all of us can work together to solve. So I think every child and individual actually represents a potential for positive change. And can we be mindful of this, and can we really make that positive change so that the mothers during their pregnancy are completely safe on every aspect, and the child and the newborn is completely safe on every aspect? Multiple studies have been done, and it has been shown that the moment there is the right intervention at the right time, which again is a clinical intervention, which all of you are amazing at, and communication and the delivery of the right kind of care, we can really overcome whatever we need to do in this space, and we should all be able to work together to do it. India as a country stands tall. India as a country has to show the rest of the world that while we have a huge population, every mother is there and will be looked after by anyone in the environment surrounding her, anyone who is making policy decisions for safe motherhood and for her safe delivery. And for children, basic nutrition, basic sanitation, good clean drinking water, a safe environment, and today a COVID protected environment has to be done and has to be ensured. Coming together, groups like all of us, we can put together a charter, we can put together a set of things to do, and I'm sure we can deliver this for us. I'm so proud to be an Indian. I'm so proud to be among this wonderful group of clinicians, young ones like Dr. Patel or Erika or Dr. Juhi, and senior ones who can really, chart the territory of healthcare for all of us. So I think you have a wonderful combination of great clinicians, and we're all here to help, to support, to communicate, and really roll up our sleeves and do what we have to do. So thank you for the invitation, and I'm delighted to be part of this wonderful group and this wonderful audience. Thank you. Namaste and Jai Hind.
Thank you, ma'am. What a wonderful address. Ma'am, you have a reputation of a dynamic young leader, and your speech today has truly lived up to that reputation, ma'am. And the way you spoke about empowering mother is just not a very contemporary subject, but has added different perspective to it. So really, thank you, ma'am, for giving your valuable inputs. I think it will be a food for thought for later on also for every one of us. Thank
you very much, Dr. Kargi Patel, Dr. Erika, and other leaders. I'm extremely happy we could get Dr. Preeta, madam, addressing to us in a very positive way. First of all, from the Indian Medical Association, we would like to wholeheartedly thank their Apollo group for being with us and raising our voice when we wanted them to help us in the raise the voice in unison to support for the Save the Savior program. We always remember with gratitude the Apollo group is doing extremely well for the entire medical fraternity and for our society. I had a privilege to have Madam in the installation function of when I was installed as a national president. So it was my great privilege, and they are with us today to support us. But it is a phenomenal event has taken place. Erika, you have surpassed all our dreams and expectations. I am getting reports from across the country, small branches, including Kashmir. They are organizing Safe Motherhood Initiative program. Assam, what they do to screening that entire started already done. It is my vision of Indian Medical Association on this positive note is something doing very good. I am sure you will be able to present us a concrete report at the end of the year. The maternal mortality and morbidity of our country has been palpably reduced because of this great effort which you are doing. Keep going. It is a great effort. I'm extremely delighted. All our leaders are behind you, and we want to support you all. Please, I'm really have no words to express my gratitude for all the good things you people are doing. Thank you very much.
Thank you so much, sir. Thank you so much, sir. We also have our Honorable Secretary General, Dr. Jayesh Lele, sir.
Yeah, I'm audible?
Yes, sir.
Yeah. Respected our National President, Professor Dr. Jayalal, our today's guest speaker, Mrs. Preeta Reddy, our today's moderators, Dr. Gargi Patel and Dr. Juhi, and of course, Dr. Erika Patel, who has done the fantastic job of last 1 week. In fact, day by day, the reports what we are getting across India, as our National President mentioned, small branches are asking us to arrange this, give them Zoom link, give them some topic speakers, or arrange some small programs for them. And really, we are overwhelmed by the response what we have created. And just like how, with the, of course, advent of this Zoom, across India, day by day, our attendance is increasing. We saw that, on the first day, the attendance was less, but subsequently attendance has increased. And this topics, today's topic, especially prenatal to postnatal, is a very, very important topic regarding vaccinations, regarding normal delivery, regarding the safe delivery, and especially in the today's COVID area, as Madam explained, the issues what we see today will be definitely very important to all the pediatricians and well as obstetricians. And I'm sure the week-long program will have a good recordings. I would request Dr. Erika to, if she can pass on all the small recordings to us, we will lodge it onto the website, because our intention is that this all important talk should go to every member of the associations. And I'm really will be very happy to put it on the website. We have already created one special web page. All links will be uploaded onto the website, and anybody can download it, and the link will be sent to every member. So that is my, I feel that such an important topic, small, this thing, recording, you can give it to us, and we'll do the job of cutting and putting it onto the website, and it will be very useful to us to refer in future, and definitely all our members will be happy to listen again. Especially our Madam Preeta Reddy she spoke about the importance. She spoke about the prenatal and the postnatal issues of the children. And really, I'm very happy that this program was launched on the 1st July, and now the entire 1 week is storming across India. All the best to Erika, and I'm sure she will come out with some other better and definitely some different program in future also. Thank you so much. All the best to every member of this association and Erika Patel. Thank you.
Thank you so much.
Already another assignment is given to her now for August 15th.
Oh, thank you, sir. Thank you, sir. Thank you. That's what I was expecting, sir.
And next, I would like to invite Dr. Gargi ma'am to introduce the next speaker of the day so that our talk can start.
Thank you once again, Ms. Preeta Reddy, for your excellent talk. Thank you.
Thank you, Preeta ma'am. Hello, am I audible?
Yes, ma'am, you're audible.
Okay, thank you very much, Preeta ma'am, for your inspiring words. Listening to you was indeed a treat for me today. And your motivating words will surely help us. You giving so much of tips to us also. Thank you very much, Preeta ma'am.
Thank you.
Thank you. Now we move on to our today's webinar topic, that is a journey of a baby, prenatal to postnatal. It is said that making a decision to have a child is momentous because it is to decide forever to have your heart go walking outside your body. That is a very precious decision. Prenatal journey of a baby start with fertilization, formation of zygote, implantation, presentation, and the formation of embryo, and finally the fetal development. Feeling the baby moves in and kicks inside the mother's abdomen, fills the mother with joy, and that is unmeasurable. It is said that baby is the only person who knows what a mother heartbeat looks, sound like from inside. So now we listen more about the prenatal journey of a baby from our first speaker, Dr. Juhi Choksi. Juhi, please slide. Juhi, okay. Dr. Juhi is a pediatrician. She is an associate consultant at Madhukar Rainbow Children Hospital, New Delhi, pediatric fellow at Royal Albert Edward Infirmary, UK, member of the Safe Motherhood Committee, National Indian Medical Association, frontline worker since past 1 year in COVID work, experience of more than 8 years in the field of child health and care. She has an extensive experience in pediatric ICU and neonatal ICU also. Apart from this academic activity, she is a very good in Mysore and Tanjore painting artist also. And she is not mentioned, but I am not mentioning she is a very good marathon runner also. And above all, she is a mother of very cute 3-year daughter, Ira. So, welcome, Juhi. I request Dr. Juhi for your speech. Over to you.
Thank you, ma'am, for the wonderful introduction. And now I would like to, without wasting much time, let me just begin with the first talk of the day. And I will be sharing my screen. So prenatal journey, as we know, the beginning. Very good evening, everyone. Again, I'm Dr. Juhi Choksi. I'm consultant pediatrician, a member of Safe Motherhood Committee. So prenatal period is defined as a time period between conception and delivery of baby, which is approximately 270 days. So UNICEF has defined this period as a very unique and critical period of opportunities when the foundation of optimum health, growth, and neurodevelopment across the lifespan are established. So very important critical period where all the foundations of different organ systems are being laid. Their function starts right in the prenatal period. So factors that weaken this foundation leads to earlier mortality, that is shortened life, and significant long-term morbidities in the form of non-communicable diseases like coronary artery diseases, like obesities, like infertility. And more insidiously can lead to substantial loss of neurodevelopmental potential. Now, the thinking question here is, imagine a baby who has been given a poor prenatal care is born on the day one of life with a higher risk of non-communicable diseases in future, and even more, a baby who is already born with a poor neurodevelopmental potential in future. Imagine how much that baby will be able to contribute to his family. and more so to his country. So this prenatal care, the prenatal period is the very bedrock, very basis of the foundation of a developing country. And that is one reason this period has been included in the various health policies throughout international and national bodies. So what are the environment that weakens this foundation of prenatal period? First is maternal nutrition. It always tops the list. And then there are maternal diseases like uncontrolled diabetes, uncontrolled hypertension, environmental exposure, maternal stress, maternal lifestyle. So I'll be discussing, and we will talk about this later in the presentation. Now, let me give you a concept of genetics and epigenetics. Now, as we know that the genetic influence in the development of different organ system in human is only 20%. Rest is all epigenetics, which is a continuous interplay between a gene and environmental factors leading to a developing genome. So the brain development, immune development, metabolic development is not just based on gene. Gene is just a blueprint. It is its regulation and its expression is dependent on the environment. Environment like nutrition, like environment like a good healthy lifestyle. So all of this environment is in our control. We can totally control and we can totally give rise to a human which is 100% healthy and has a apt neurodevelopment potential. So this interaction is maximum in the last trimester and in the early childhood years. So I would like to add here that positive environmental factor is very, very essential. Now, the whole purpose of this prenatal care is to give a good start. So it is seen, and the research has found that a baby who's given a good start goes further ahead in life. So a baby who's given a good start is 10 times, he's able to overcome many diseases. He's able to get good grades in school. He's able to earn better in life, and more so ever can give rise to a healthier family, and a healthier family can give rise to a healthier India. So the impact is on generations. So how does this poor prenatal care leads to poor neurodevelopment potential? So let me explain this by concept of development plasticity and development programming. So development plasticity is defined as the phenomenon by which a single genotype can give rise to a range of different physiological or morphological states in response to different environmental conditions during development. In a simple words, plasticity allows an organism to attain a phenotype which best suits it can cause permanent changes in the reproductive system, metabolic system, cardiovascular system, and other system, giving rise to hypertension, stroke, and coronary artery diseases, to obesities, to altered reproductive endocrine functions. Now let me take you through the normal journey of the pregnancy. So I will be covering only the fetus part, and I will not be giving so much of importance to the mother part as it has already been discussed before. So coming to first trimester, it is 1 to 13 weeks. All the organs starts to develop, brain, heart, and kidney by 3rd to 4th week. And the first sense to develop is touch at around 8 weeks, just 2 months. So when the mother strokes her belly, that's the first way of communication that a mother forms with the baby. So at 12 weeks, a child can tell about the environment. The feeling of heat sensation develops. At 12 to 13 weeks, the feeling of taste and swallowing develops. At the same time, a mother is registered, And this registration is very important. As a mother who's registered, we all should reckon to this. A mother who's antenatally registered is followed up best. Her vitals is recorded, her BMI, her BP, her height is recorded. At the same time, mothers go through certain blood investigations for blood grouping, for any screening of intrauterine infections. And mother also goes through a first antenatal scan to confirm the pregnancy, and also in the later of the first trimester it tells about the nucleotranslucency. And the treatment that is given in the first trimester is folic acid, which should be started preconceptionally at least 3 months before. Coming to second trimester, we all know it's a golden period where there is a rapid growth and differentiation of different organ systems. Baby starts kicking, a mother can feel the kicks, and at 18 weeks, hearing, listening, and learning starts. So this learning is at 18 weeks, the prenatal memory start. A baby can recognize mother's voice at higher hertz, at 250 to 500 hertz, and father's voice as 125 hertz. A baby is also very responsive to light and develops pattern of sleep and activity. At the same time, it's very important to mother to go through fetal anomaly scan, a down screening, and a vaccination that was given in first trimester. The booster dose should be given in second trimester. And the treatment, the supplements that's given is iron, calcium. There are more supplements. I will be telling about it later. So third trimester period between 27 to 40 weeks, where learning and memory defines, and there is rapid development of neurons. At this time, the mother should know about baby movements, and there is a swelling of feet that develops in the third trimester because of the pressures. Stages of brain growth and synapses. So at around 4th month, a brain is just a bilobe structure, just like a coffee bean, and it goes on in the third trimester. It goes on to develop into a complex walnut-like structure. Now, coming to the very basic of neuron, at 3rd week, the neural tube formation begins, and this neural tube differentiate itself at around 10th week, and then the neurons migrate to its location where it is going to give rise to different structures of the brain. And at 15th week, the structural formation begins. Now, this at 15th week, the synaptogenesis, the contact between two neurons, there is the communication between two neurons starts, and the synapses that are formed in 15 weeks is in millions. It is rapidly forming, and once the synapses that are formed reaches its maximum stages, the synaptic pruning starts. And this synaptic pruning, I would like to add here, is very much environment and experiences driven. This synaptic pruning goes on till adolescence. So I'm not saying that if anything wrong happens in this period, it is gone. It's not that. It goes till adolescence. But what I'm saying is that the lower systems in which the synaptic pruning is happening, and at the same time when it is coinciding with the architecture of the brain. So any injury in the last trimester, I would like to add, where the synaptic pruning begins, can have a permanent effect on the neural structure of the brain. So this was a study done in Harvard University, where it states that the synapse formation depends on early experiences and the synapse formation that is happening at a very high speed, at 700 per second in the early years. Look at this graph. The sensory pathways of vision, hearing, and language, as we can see, already starts developing. A baby can hear, can listen, can have a little bit of language perception already before birth. And this is highest. This goes at the highest in the first year and then finally declines in the later part after 2 to 3 years. So what can we do to give a good prenatal start to the baby? First thing is, it's very, very simple. It's maternal nutrition, tender loving care to mother, a mother free of stress, no substance abuse, a healthy mother free of diseases, and a positive environment. So let me talk about maternal nutrition. Pregnancy does not mean, as we all know, eat for two. In fact, it is only 10% higher energy requirement than the normal women. What is needed is extra micronutrients. So iodine is needed for IQ, iron is needed for brain development, folic acid is needed for birth defects, vitamin B12 again for birth defects, calcium and vitamin D for fetal bone development, and omega-3 acids for brain and vision development. So stress in mother. So it has been seen that stress in mother, a mother who is in anxiety, it affects the height, weight, and all head circumference, and these are the biological indicators of the baby, of a healthy baby. So it has an effect on all three. Stress in mother causes blood flow in the baby, which makes it difficult to carry oxygen to all the important organs that are developing. And invariably, a mother who's stressed has increased cortisol in the body, and this has a direct consequence on the growing brain, especially hippocampus area. And hippocampus area, as we know, is known for learning and memory. It has effect on development delay. So we don't want cortisol in the body. What we want is oxytocin, endorphins. Or it is also called a collect and a protect and a love hormone. And how can you increase this oxytocin? It's very simple. By giving tender love and care to the mother, by helping her to socialize, by giving her a positive environment, by listening to music, and by doing prenatal yoga, which is already been discussed by Dr. Erica in her previous sessions. Next, coming to a healthy lifestyle, we must counsel against alcohol, nicotine, and substance abuse. No amount of alcohol is safe in the body. An organ, it can at any point of time, even the second trimester, even the third trimester, the organogenesis is happening, and it has known to cause different. It's a teratogen and has known to cause defects in heart, eye, palate, ear, brain. So as we know, we are seeing more and more cases when, science is adding logic to the mythology, especially the Indian mythological facts. So this is a picture depicting Arjun telling his wife about the Chakravyuh, getting out of Chakravyuh, and Abhimanyu listening from the womb. So this is the first sign of prenatal memory, which has been already stated. So with this, I would like to thank you so much.
Thank you. Hello. Thank you, Dr. Jui. Am I audible?
Yes, ma'am, you're audible.
Thank you, Dr. Jui. That was an excellent presentation and very informative session. After the prenatal journey, now we move on to the birth of a baby. The birth of a baby is heralded by the first cry and the first breath. It is the only time in the life that the cry of a baby makes the mother happy. It is the only one time that the cry of a baby makes the mother happy. And as well as the pediatrician and gynecologist also. The first breath is very important and powerful. It pushes out the alveolar fluid from the lungs and fill it with life-giving nectar, that is the oxygen. If a baby does not breathe at a birth, baby will require the resuscitation. And the birth asphyxia will lead to the complication and morbidities. in future. And now we have a very good neonatologist and pediatrician, Dr. Naveen Prakash Gupta sir, who tell us about the importance of the first breath. Now, Dr. Joy, please share the slide. Yes, sir is a MD Pediatrics, DNB Neonatologist, Fellowship in Neonatology and Perinatal Medicine in BC Children Hospital, Vancouver. At present, sir is a senior consultant neonatologist in Madhukar Rainbow Children Hospital, Delhi. His area of interest are care of extremely preterm baby, neonatal hemodynamics, neonatal ventilation, POX, that is a point of care sonography. We are lucky to have you, sir. I request you, sir, for sharing your talk. Over to you, sir.
Thank you, Dr. Gargi. And so is my screen visible, Dr. Gargi?
Yes, sir. Yes, sir. It is visible.
Okay.
You can start.
Yeah. So thanks for the nice introduction. And at the outset, I would like to thank IMA for doing this marvelous job of conducting this whole week on this very important topic. And thank you for involving me in this academic feast. So without wasting much time, in the next 15 minutes, I'm going to take you the journey of a very important part in the newborn or any baby's life, that is the first breath. So basically, what changes? There are many changes which are happening when the baby is taking the first breath. The physiology is different when the baby is inside the mother's womb, and now the baby has come outside in the outside environment, and things are different. So majority of the time the transition is very smooth, like whatever has to happen, it happens smoothly. But sometime when it doesn't happen smoothly, then the baby may suffer the consequences, because this is a very vital period in which deprivation of oxygen to the organs of the body, especially the brain, can lead to long-term consequences in the form of neurodevelopment impairment. And that we say that the child has suffered birth asphyxia at the time of birth, that leads to hypoxic ischemic encephalopathy, and that leads to cerebral palsy later on. So at the our goal as a pediatrician, as a neonatologist, or the obstetrician goal is that to give a healthy baby to the mother who has spent 9 months in who she has nourished the fetus, so she wants a healthy baby. So this first minute is very, very important, or immediately. So let us see what is happening when the baby is inside the mother's womb. So the circulation of the baby is different actually. So there are 2 or 3 shunts which are present. One is the foramen ovale. Foramen ovale is the foramen between the 2 atria, and the blood is, there is a right to left shunting happening, and the blood, in spite of going from the right atrium to the right ventricle, majority of it is diverted towards the left atrium. Why it is happening? Because lungs are filled with fluid and they are not taking part in the gas exchange. What is the site of gas exchange when the baby is inside the mother's womb? The site of gas exchange is placenta. Then there is a ductus arteriosus. Whatever little blood goes to the right ventricle and through the pulmonary artery, in spite of going into the pulmonary circulation, the blood is diverted through the ductus into the aorta. And the third is ductus venosus. So this everything closes actually immediately. The function closure starts immediately after birth, and the anatomical closure sometimes take 24-48 hours to happen. So basically what is there in the intrauterine phase? The lungs, they are filled with fluid. Pulmonary vasculature or pulmonary vessels, they are constricted. They don't have any blood flow. And like the thing which is happening in us, that lungs are the main site of oxygenation. In fetus, the site of oxygenation is placenta. The baby, the fetus derives its oxygen from the maternal blood through the placenta. Now, when the baby comes out, and as soon as we clamp the umbilical cord and we are cutting the connection between the mother and the baby, now the baby has to survive on its own. So, what happens with the first cry, which is synonymous with the first breath, the lungs are filled with air. As soon as they are ventilated, they are filled with air. The pulmonary vascular resistance means the pulmonary vasculature, which is encircling the alveoli, it relaxes. As soon as it relaxes, the blood goes through the lungs, and then that blood gets filled with the oxygen, and then oxygen is supplied to the heart, and heart supplies it to the body. So the first breath or first cry is important for all these things to happen. So if we look at the overall data, majority of the babies, 90% of the babies, they don't need anybody. They will cry immediately after birth, and you hand them over to the mother and start breastfeeding, and job is being done. 5% of the babies, they require some assistance, like they require a little bit of drying, little bit of stimulation so that they can start breathing. 3% of the babies, they require some bit of positive pressure ventilation, like they are not breathing on its own and they require some assistance. You start positive pressure ventilation with a device which can deliver positive pressure ventilation, like a ambu bag or T-piece resuscitator. Ambu bag is also known as self-inflating bag. Very few of these babies, they require extensive resuscitation in the form of chest compression or drugs to initiate the heart. So there is a program which actually every pediatrician or neonatologist or the nurse who is attending delivery should know about it. The program is called Neonatal Resuscitation Program. It is the whole word is it is being validated, and it actually starts the American Academy of Pediatrics. Now the countries with minor changes, they are running this program, like we have a NRP, NR India program also. So everybody, every pediatrician, neonatologist, nurses should be trained so that in this program, so that we follow a protocolized approach. What is the benefit of a protocolized approach? It will be a teamwork. Like one person is giving the command and the other person is understanding that, okay, at this step we have to do this, at this step we have to do this. So it actually starts before delivery. As soon as we get a call, we need to do some antenatal counseling to the mother, especially telling her about the importance of the early breastfeeding, importance of when the baby cries immediately after birth. We will hand over the baby to you and you start immediately breastfeeding. Then we need to understand what is the we ask 4 questions. What is the gestational age of the baby? Because the premature babies, they need extra care, as we will learn later part. Whether the amniotic fluid is clear. Why? Because meconium, if the amniotic fluid is meconium stained, then meconium actually baby passes in response to the stress or in response to the hypoxia he is having. So we need to be more cautious, and there are certain times these babies, they are at higher risk of requiring intubation or ventilation in the delivery room. Any additional risk factor are present, like abruptio, or mother is having some illness, or there is RH isoimmunization where we are dealing with an hydropic baby. And we also need to discuss the cord management plan with the baby, because we will be discussing in the coming few slides whether we should clamp the umbilical cord immediately or we should delay it for 30 to 60 seconds. Then pre-resuscitation team briefing, like the nurse and the doctor who are going to attend the delivery, they need to talk. Okay, suppose the baby needs intubation, you are going to do the intubation. Suppose, are you comfortable with it? Suppose the baby needs chest compression, who will be the team leader? Who will be the person who will be doing it? And equipment check, which is very, 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 very important. So because this is like we are dealing with the life of a child, so at least the equipment and the infrastructure should be working. It should not happen like we haven't checked that whether the suction is working or not, because at that time, if the things go wrong, everybody gets anxious and that leads to more catastrophe. So always go in the manner of TABCD, which has been taught in adults and pediatrics. It is ABC, airway, breathing, circulation. Newborns, they need to be kept warm. So it starts with the temperature. T is for temperature, A for airway, B for breathing, C for circulation, and D is for the drugs. So this is the algorithm. This algorithm has just come recently from the American Academy of Pediatrics NRP program 2020. So I will just take you through it in the coming few slides. So what happens if we look at the uppermost box? Antenatal counseling has been done, team has been debriefed, equipment has been checked. In equipment, we should check all the equipment starting from the radiant warmer. Put the radiant warmer on a manual mode at least 10 minutes before the delivery so that there is a preheated environment is there. Check the suction, ensure that the suction pressure is not too high, not too low, and it should be somewhere, it should not be more than 100 millimeters of mercury. Check oxygen is there, check stethoscope is there, check your ventilation device is working, whether it's a self-inflating bag or it's a T-piece resuscitator. Then you need to check that your laryngoscope with the appropriate size blade is there and it is working. Then you need to check that you have an endotracheal tube of sizes ranging from 2.5 to 4, and you can decide depending on the weight of the baby that which size you are going to go. Then you should have a pre-filled adrenaline. Adrenaline injection comes in 1 ml. You need to mix it with 9 ml normal saline and then keep it in a syringe which has been labeled. And then you have umbilical lines also, because sometime if we need to put the umbilical lines there only, we can do that. You have equipment for cord clamping and you have vitamin K ready. So if everything equipment has been checked, now the baby is born. So what are the scenarios? So you can see that in the first colored box, you need to ask three things at the time of birth: whether my baby is a term baby, good tone, breathing, or crying. Always remember, if the baby is crying overly, his muscle tone will be good only. And term gestation, we tend to know before birth only. So basically, what we are looking is whether the baby is breathing or crying. If the baby is breathing or crying, if the answer to this is yes, then we don't need to take the baby on the radiant warmer. Just keep the baby with the mother only. And in the subsequent slide, I will show you the picture. How do we do it? You put the baby on the mother's tummy and dry the baby there only, and then you put the baby to the breast, and then you cut the umbilical cord after 60 seconds. That is called the delayed cord clamping, which is very, very important. Suppose the baby is not breathing, suppose the baby is not crying, so baby is apneic. You receive the baby in a pre-warmed sheet, you take the baby to radiant warmer, and you do the steps which are known as initial steps. And what are the initial steps? You warm the baby, you dry the baby, you stimulate him so that he starts breathing. You position the airway by putting the shoulder roll beneath the shoulders or by putting your hand so that the neck is in a slightly extended position, which is called sniffing position, and you suction the airway if it is needed. And you always suction mouth before nose. So after doing this, you assess whether your baby has started breathing or not. If the baby is apneic, that means baby is not breathing and heart rate is less than 100, then you start positive pressure ventilation. You attach pulse oximeter to the right hand and you consider the use of a cardiac monitor, that is ECG, because we have learned over the years that it's the ECG which leads to accurate rhythm. But if your baby is breathing, you assess. If the baby is breathing fine, you give the baby back to mother. If the baby is working too hard to breathe, like baby is having labored breathing or respiratory distress, or baby is still blue and his cyanosis is persisting, what you will do? You will again look whether there are secretions in the mouth. You will tend to suction them. You will position the airway. You will put pulse oximeter. You can use oxygen if there is cyanosis, and consider CPAP used from the delivery room. CPAP is continuous positive airway pressure. CPAP is something, you can say that one innovation in neonatology which has changed the future of preterm babies and also term babies. So this is a distending pressure, which actually you can say in layman language pushes the water out of the alveoli. So it helps the baby to breathe smoothly, and it will avoid the unnecessary intubation and ventilation also. So why this 1 minute is important? You see that with the vertical line, the 1 minute is being written. Why this 1 minute is important? This is called the golden minute, because if you do the things right in the right manner in this minute, the child will be very healthy. And if you don't do the things in the right manner in this 1 minute, the child can have lifelong consequences for that 1 minute. So we should be very active. We should understand what is neonatal resuscitation program. We should be very well versed with it before we start attending the deliveries. Now, post that, what happens if you feel that the heart rate is persistently low? You ensure adequate ventilation. You consider endotracheal tube, or suppose the person who he is not competent enough to put the endotracheal tube, he can use the laryngeal mask airway, and the baby is with the cardiac monitor. And if you feel that no, heart rate is more than 100, the baby has started breathing on its own, you shift the baby to NICU for the post-resuscitation care. Now coming forward, if the heart rate is further falling, you take, so basically there are two cutoffs for heart rate when you are resuscitating the newborn. One cutoff is 100, which decides whether you continue ventilation or not. Another cutoff is 60. If the heart rate goes less than 60, you initially start chest compression by the two thumb technique, and in the ratio of 3:1. You continue chest compression if the heart rate is persistently less than 60. Even in spite of the chest compression and adequate ventilation, you consider use of epinephrine, and that can be given by the endotracheal route and further by the IV route. And this sequence of event continues. This table is very, very important. What is the table suggesting? Target oxygen saturation table. So gone are the days when the baby is being born and we want that 95% saturation should be there. We have understood over the years that giving excessive oxygen to the baby leads to free radical injury, and the normal newborn who cries immediately after birth, he also takes 10 minutes for his saturation to reach 90-95%. So that is why there are saturation target that we should not be giving excessive oxygen to the baby, and we have targets in our mind that okay, at 1 minute target is 60-65%, 2 minutes 65-70, 3 minutes 70-75. Oxygen is a drug and it has to be titrated and it has to be used in the right manner. Excessive. So there was a time when we used to start resuscitation with 100% oxygen. But over the years, we learned that for term babies, if we start resuscitation with 21% oxygen, that is room air, then that leads to better ABGAR scores. That leads to initiation of first breath sooner, and that leads to lesser mortality. And India is one of the country who was like Dr. Siddharth Ramji from Maulana Azad. He has done some phenomenal research in this field, and he was one of the initial ones to recognize this. And now then in 2010, the neonatal resuscitation program, AAP guidelines, they acquired it. And any baby who is born more than 35 weeks gestation age, we start with 21% oxygen. Even less than 35 weeks, we have to start between 21 to 30% oxygen. So how can we give 21 to 30% oxygen? So we need blender. So another equipment which is very, very necessary in the delivery room, that we should have a blender. So it's actually a crime if we start, it's actually resuscitation with 100% oxygen, because we might be doing more harm to the baby than doing the good. So apart from this algorithm, what else is needed is, one is the cord management. We are going to discuss. One is meconium state amniotic fluid. Then how much FiO2 to start with, and the role of the drug. Okay. So coming to the cord clamping. So there was a time when as soon as the baby is being born, the obstetrician is in hurry and the neonatologist is in hurry. We clamp the umbilical cord and we hand over the baby to the mother. But placenta contains the baby's bit also. So let it be the natural process. Let's delay the cord clamping for 30 to 60 seconds. For 60 seconds, it has been seen that delaying the cord clamping for 60 seconds lead to better hemoglobin of the baby, better outcomes in preterm babies. It leads to lesser intraventricular hemorrhage also. So it has got multiple benefits. So it has become now the standard of care. So if the baby cries immediately after birth, you will delay the umbilical cord clamping. So suppose we are giving vaginal birth to the baby cries immediately after birth. You receive the baby in a pre-warmed towel. You put the baby on the mother's tummy, and we could also see a phenomena which is called breast crawl. The baby automatically searches for the breast, and he can start breastfeeding. So, and you wait for 60 seconds and then you clamp the umbilical cord. But if the baby is not breathing, then it is very, very important that we have to start the resuscitative efforts. We have to start the resuscitative efforts. So always remember that when we have to start the resuscitative efforts, we have to clamp the umbilical cord immediately. So there have been right now studies because there are benefits of delayed cord clamping. There is a resuscitator which come, and resuscitator is bring in close contact with the table on which mother is there, so that the resuscitation is started without clamping the cord, and the cord is clamped after 60 seconds only. But in India, we still go with the guidelines, simple guidelines. If the baby is crying, we delay the umbilical cord clamping. If the baby is not crying, we clamp the umbilical cord immediately. Now, second question is which oxygen to start with. Although the American guidelines are taking cutoff of 35 weeks, Indian guidelines are saying 32 weeks. If the baby is more than 32 weeks, you start with room air. If the baby is less than 32 weeks, you start somewhere between 21 to 30% oxygen, and don't target too much. At 5 minutes, even if your baby is saturating 80% and heart rate is more than 100, you should be very, very happy, very, very happy. So coming to meconium stained liquor, so there was a time when the baby is born with meconium stained liquor. We feel that the meconium is lying in the trachea. We intubate the baby and we do tracheal suctioning so that we can suck out meconium, thinking that we can prevent the meconium aspiration syndrome. Now, when the baby is born with meconium stained liquor, there are two subset of babies. The first subset of baby is when the baby cries immediately. So that baby is called a vigorous baby. Vigorous baby is defined when the heart rate is more than 100. When the heart rate is more than 100, the baby is crying and baby is having a strong muscle tone. Baby is having strong respiratory efforts and good muscle tone. So that baby you can give to the mother similar manner. Only thing is, if there is too much meconium in the mouth, then you can do the suctioning. The second subset of the baby born with meconium stained liquor is when the baby is born depressed. So depressed is if any of the element is not present, that is heart rate is less than 100 or the baby is not breathing. Then you have to do the similar steps like initial steps, and then you start with the resuscitation. Nowadays, there is no role of tracheal suctioning because normally when we do the tracheal suctioning, we are losing that important minute, you can say, in which the oxygen to the brain is still hampered. So supply giving oxygen or giving adequate ventilation and supplying oxygen to the brain takes precedence over suctioning out the meconium from the trachea. And it has been seen that majority of the meconium aspiration syndrome, that is meconium going into the lungs, it has already happened in utero. So the steps of resuscitation remain same whether your liquor is meconium stained or non-meconium stained. If the baby is crying, you give the baby to the mother. Only extra thing is suction may be needed. If the baby is not crying, you do with the initial steps and then you do with the positive pressure ventilation. So how to monitor positive pressure ventilation? Heart rate is the single most important parameter. If your positive pressure ventilation is effective, then the heart rate will rise. And how do you assess the heart rate? Gone are the days when we used to palpate the umbilical cord. Then we came to auscultation and then pulse oximetry. But the ECG, putting ECG leads is the best form. So if your baby, right now the guidelines are, the 2020 guidelines are, if your baby needs an alternative airway, that is the intubation or laryngeal mask airway, we should put the ECG leads on the baby. So baby should be on a cardiac monitor. So less than 32 weeks, they need special care. So there have been ample number of studies that if we receive these babies in a food grade polythene elastic bag, then their admission temperature to NICU is more. So, and hypothermia, that means when their temperature is lesser, that is a single most important determinant of mortality. One of the most important factors for survival of these babies. So the baby should not be hypothermic. So to prevent hypothermia, we receive these babies in the food grade.
Sir, I would just need to interfere 25 minutes. I mean, if you could just wrap.
Just last two slides. So we need to receive these babies in the food grade polythene elastic bag and without drying, so that their admission temperature is good. Then the oxygen should be between 21 to 30%. So summarizing, so routine care is very important. We don't need to separate mother from the baby. Delayed cord clamping is very, very important. There should be no cord milking, especially in the preterm babies. Effective ventilation. If you ask me what is the most important step in the neonatal resuscitation, that is effective ventilation. Rising heart rate is an assurance that his ventilation is effective. Non-vigorous MSL, no intubation, and 21% oxygen beyond 32 weeks. And chest compression, intubate, 100% oxygen and thumb. And overall, this is the golden minute, or this first breath is very, 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 very important. Thank you. Thank you. Over to Dr. Gargi.
Excellent presentation.
Excellent presentation, sir. Golden minute you described very nicely. Thank you very much, sir, for informative session. Over to Dr. Jui.
So that is a memento for you for the excellent presentation that you have given, sir. Thank you so much. It was truly an academic treat related to first breath of the baby. Now, next, I would like to invite Dr. Gargi, madam, to introduce our next speaker. I'm sorry, I would like to invite Dr. Chalapati, sir, to introduce our next speaker, that is Dr. Baldev Prajapati, sir.
Thank you, Dr. Juhi. Good evening, everybody. At the outset, I would like to thank the organizers for giving me this opportunity to chair this session. This is the 5th day of the Safe Motherhood Week. Respected National President Dr. Jayalal sir, the Honorary Secretary General Dr. Jayesh Dele sir, senior IMA past office bearers, and all the WDW office bearers and members of IMA. It is in fact a wonderful feast, scientific feast that has been brought out by the WDW team at the national level since 1st of July. And we have to thank the headquarters, IMA headquarters president particularly for bringing out this wonderful program. After the words of wisdom by Dr. Preeta Reddy, then Prenatal Journey and First Breath, and particularly I being a pediatrician, I really enjoyed the session of Dr. Naveen sir. So after the child is born, now starts the postnatal journey. And to deliver such a wonderful talk, we have a great speaker in Dr. Baldev S. Prajapati sir. And he did his MD Pediatrics, and currently he's the head of the Department of Pediatrics at GCS Medical College Hospital Research Center, Ahmedabad. And he's got a lot of honors, particularly Dr. Mrs. A.B. Desai Oration, Dr. Tapan Kumar Ghosh Oration, and IAP GSP Olympic Traveling Fellowship. He has got more than 96 publications for his credit in national and international journals and indexed journals, and he has given more than 1,500 lectures at various platforms. And he was an executive board member of Central IAP and member of IAP Committee on Immunization 2010 and 2017, the chairperson for Infectious Diseases Chapter IAP 2009, and was also a president of IAP Gujarat State during the year 2000. He'll be talking on the postnatal journey. Sir, over to you, sir. Dr. Prajapati, sir.
Yes. Good evening, friends. At the outset, let me express a word of gratitude to the organizers for giving me this opportunity. The topic given to me is a postnatal journey. Let me start share the PPT. Thank you very much. I think at the outset, let me express a word of gratitude to our Vice President, Dr. Gargi Patel, Dr. Erika Patel, and all other friends, organizers for giving this opportunity. The topic given to me is this postnatal journey. I think before I come to the topic, let me state some eye-opener facts. Friends, 26 million births each year in our country, and which comes to almost 1/5 of the global. And of these, almost 0.8 million infants die before the completion of the neonatal period. It's a little bit old data, but I think almost the same, and which comes to 1/3 of the global neonatal deaths. And the neonatal period, that is first 28 days of life, all of us know it carries the highest risk of mortality per day and any other period during the childhood. So this period is very, very important, what I want to state. And 70% of the total infant deaths and more than 50% of under 5 mortality rate fall in the neonatal period. Almost more than 45% of total under 5 mortality rate is contributed by early neonatal period, that is first 7 days of life. The point is, this time is very, very important. And now if we want to break down infant mortality rate or under 5 mortality rate of our country, I think we'll have to focus to this problem. And for that, one of the points which already Dr. Naveen has addressed is very important. If we try to localize that, which are the most common reasons for the neonatal deaths, first comes birth asphyxia, which is absolutely preventable, and that will have to start from the antenatal period, as Dr. Naveen stated. Second, sepsis, prematurity, low birth weight, and congenital malformations. Again, you know that most of these, out of these three regions are preventable. Asphyxia, prematurity or low birth weight, and sepsis. Now, I'm sure that these pediatricians, neonatologists should focus on this problem. And unless probably we are able to do something in these areas, we will not be able to break down the infant mortality rate or under 5 mortality rate of our country. Friends, we have to understand it very clearly and distinctly what even Dr. Neeraj Gupta was discussing. Neonate is not a miniature of any adult or a child, not even an infant. It's a total different entity that we have to accept it. Preterm, IGR, full term, post term, all are different. Their needs are different, their problems are different, and that we have to understand. And we know that here the increased risk of morbidity and mortality. All of us know that approaching these babies is a unique challenge. Even to get the information, history is not so simple. And friends, all of us are practicing, we know that whatever the problem with the newborn, symptoms and signs are same. Stop to take the breastfeeding, become the lethargic or inactive, whatever the reason is that. But we'll have to develop a clinical skill that what type of problem it is. And we know that even how to examine the baby. Even one first-year residency, after the completion, that person is not competent enough. Even many times, even senior persons, because it's not so simple. And I'm sure that unless we are capable of doing these points, we'll not be able to help these babies. What are the basic informations we'll have to collect in the history? I may not go into the details, but all of you know it's very important. The details of the parents is very important, specifically mother. Maternal age is important factor. Younger the mother or even the advanced maternal age, both the factors are playing the role. Even paternal age is also important. Education, of course, plays the role. Past obstetrics history is very important, particularly every pregnancy will have to go in the details. Interval is also very important. And by chance, if you come across recurrent abortions or stillbirths, please think for the diabetes mellitus, syphilis, RH problem, or internal cause incompetency. Maternal health status is very, very important. And I think initially Dr. Juhi was focusing that we'll have to understand that maternal nutrition plays a maximum role in the country like India. Even chronic illnesses of mother, especially the anemia, and some chronic diseases like hypertension, even UTI. Maternal endocrine disorders are also equally common in the practice, particularly diabetes and the thyroid disorders. Even obesity is also now coming up like anything. Blood group of the mother, I'm sure that every pediatrician is doing its importance. We'll have to focus on maternal immunization. Some of these parties remain unaddressed. We'll have to see that any problem to the mother during pregnancy, especially fever and rash, which drug mother is receiving is important factor. What her diet is intake, and what even the yearly some USG scan is done, especially at 18 to 20 weeks to screen the malformations, and whether the mother underwent any diagnostic or therapy procedures. Friends, what I want to share, probably all the things or facts are known to you, but to re-emphasize that somehow we are missing the practice and paying a lot after this follow-up. We have to know exactly what even Dr. Naveen was insisting that before attending this call, you should have the full information and that details of the history, especially the rupture of membrane, even PV examinations, even the duration of the labor, and each step of the delivery, because it indicates you exactly the situation. Coming to the point of the postnatal, at the Apgar score, he was talking that what is its importance. Next, we'll have to go for the feeding part. Even see that the baby has passed the meconium, at least latest by 24 hours and urine by 48 hours. I think again, this injection vitamin K, so much we are insisting, we are discussing, but still occasionally this part is missed. And later on, we face the problem of, all of you know, hemorrhage disease of newborn with greatest damage to the baby. So I think this is very important factor, which probably we should even pass on to the other healthcare workers also. Birth vaccines are very important, and before the discharge, every baby should be vaccinated. Of course, we'll have to see the common problems of jaundice, seizures, feeding problems. And friends, please remember, any mother complains of vomiting, that too either the blood containing or bilious. Very, very important. The blood containing may be the maternal blood or in the true sense hematomesis. And bilious vomiting, it is said that even single bilious vomiting, please never take it lightly. It requires the proper attention. It is possible that you are facing some surgical condition. unless you have excluded. Of course, if when I say admission, we'll have to go in the details. Examination is very important, but I think every person should be trained. But what is your aim? What is your goal of examination at every specific time? Suppose at the birth you are, then what it is expected that you should check it. Very specific number one, need for resuscitation, which already Dr. Neeraj Gupta has addressed very nicely. Later on, please check for the major or the life-threatening some congenital malformation, like congenital diaphragmatic hernia, tracheoesophageal fistula, or any serious cardiac malformation, which can be even duct dependent. And if you don't address it, if you don't understand, within a very short time, baby may become the serious or you may lose the patient. So I think that's very, very important. We'll have to train our mind that what is to be checked when you are there to see the baby. Identify the high-risk newborn, suppose the infant of diabetic mother, or even the large baby, or very bad obstetric history. So you'll have to identify these some points that what are the likely creating the problem in the future with the baby. And of course, we'll have to support the baby for the physiological transition. So I think these are the goals of our examination at the time of birth. I think before we send our resident for this purpose, he should be aware that what is his role. Even when you examine the baby, second visit should always be there at 24 to 48 hours. Again, identify the high risk. See for the gestation and growth. Check for the major or minor or some occult congenital malformations. And whatever the problems with the mother, always we'll have to address. Please never say that the mother is vague, mother is illiterate. I think these type of the comments indicate that we are not competent enough to understand the parents. Any mother can never be illiterate to complain regarding her baby. There is no need, I will say, of any education to understand her baby. And she can never be the vague. On the contrary, she will be having the maximum information. And we are not allowed to ignore any complaint of the mother. Afterwards, even on follow-up on third or seventh day, regarding the high risk, you will have to check. Growth is very important. Behavior of the baby is very important. Many times what we are discussing in the older children, higher functions. Here, what are the higher functions? Behavior of the baby. That's how the baby is taking the breastfeeding, even pattern of taking the breastfeeding, regarding its sleep, regarding its activity, passing the urine and stool, its posture. Every aspect is very important to provide lots many informations. Some physiological variations we'll have to check it, and if you are not accustomed, I know simply many a times my first year resident will say, sir, child is having the respiratory distress. And when I see, oh, it's a periodic breathing. So I think these type of some physiological variations regarding even the seriousness and demarcate this physiological, if it is not done properly, then also we are missing the conditions. Of course, nowadays perform the clinical as well as metabolic screening. And I think this is very, very important. Gratuity is coming up in our country. And if the parents are affording, I think that we should not miss, particularly the metabolic screening. And nowadays, various facilities available that we should utilize it. And any mother complains in emergency visit, don't miss it, particularly the life-threatening event. Even the sick newborn. Sick newborn and normal newborn, even many times it becomes difficult. Always it is my instruction to my resident that if you are not able to decide, call your senior or hospitalize the baby. I think next day, suppose observation, if you are happy, you can discharge and explain further. But it is very risky to send the baby at home because you are not able to decide. All of us know that even the well-looking baby with a fever, it's difficult to say that this is very simple viral or dehydration fever. It can be the bacteremia, and 20% of this group will be bacteremia. If I don't understand, they will get to the serious problems, can die. So I think that's the thing which we have to train to our students, and we'll have to translate in our practice. Again, identify the severity of any illness. So these things are, I would say, quite different compared to the older children or adolescents. Examination, I think all of you know, I may not go into the details, that vitals, especially jaundice, pallor, and cyanosis. Cyanosis may not be that easy, and that we'll have to check it because early missing the cyanosis may create the problem. Anthropometry, weight, length, and head circumference, very, very important. I would say not just measurement, plotting the growth chart. And later on, follow the growth chart, which will provide lot many informations. Check the head size, shape, caput, capillometoma, anterior frontal, posterior frontally. Look at the baby for dysmorphism. Check every orifice if they're having any problem. Genitalia, absolutely important, not to miss even the several conditions like undescended testes or even the hypospadias or many things. Check the back, spine, and hips. The back, even tuft of hair may be indicating some major congenital malformation. So I think every point we have to check it. In the systemic examination, I will say to my students that put the stethoscope, look at for this air entry. Many times, suppose left side air entry diminishes, heart sounds on the right side, and scaphoid abdomen. I think it is very clear that congenital diaphragmatic hernia. So I think from simple your points of examination, you can derive that lot many problems are there. CVS, particularly the precordium, if it is silent precordium, still heart disease, it means it is some decreased pulmonary blood flow. But really, if it is hyperactive precordium, it indicates some serious cardiac problem with the CCM. As I talked to in location of apex beat, I think measurement of SPOT in all the four limbs is very, very important. Not only, I will say, only upper limb or one limb. And if you want to measure not in all the four limbs, that minimum right upper limb and one lower limb is must. Look for the murmur. I think abdomen provides lots many information. Scaphoid abdomen, it is said that the scaphoid abdomen in child is having the breathlessness. It is a congenital diaphragmatic hernia. If it is a scaphoid abdomen in bilious vomiting, I think very classically it indicates duodenal atresia. So I think these are the simple points, provide lot many informations. Organomegaly, check for the urinary bladder or even sometimes any mass. Neonatal reflexes, we know that for CNS status, we can check simple reflexes. There are more than 73 reflexes as Illingworth has described, but I think for general pediatrician, 8 to 10 reflexes are more than sufficient. Check for the muscle tone. Very important eye examination, particularly daily reflex, not to miss either the cataract or retinoblastoma. Always look for the eye reflex, that is the red reflex. And if you perform this habit, you will never miss the cataract or the retinoblastoma. I think postnatal care, these points are very important. We'll have to now translate even to our healthcare workers. Clean hands, clean delivery surface, clean cord cut, clean cord tie, and the clean cord stub. I'm sure that this will prevent many problems of infections. I think what Dr. Neeraj was discussing, this is very important. As far as possible now, don't keep the baby away from the mother. I will say as soon as the baby is out, keep the baby on the chest of the mother. Very nicely, he was insisting that with the crawling of the baby. And I came across a very good video, which is showing that how the baby is crawling toward the breast of the mother. I think what even the beauty you want to see, what the nature has created, why we should disturb it. I think this is very important. Zooming in is a lot many advantages. Improving the bonding, even the breastfeeding, infection will be prevented, temperature is maintained, KMC is best answer, all of you know. Even increase the mother's confidence for carrying the baby and reduces even the nursing care also. I think we are highly convinced with this and see that it happens in our practice daily. His friends, I would say no any importance of the breastfeeding can be assessed, and we should not be the party or component of damaging this component of the breastfeeding. No prelactal feed. Every baby should get the colostrum. All of us know that colostrum is rich from several immunological components. So many proteins, so many substances are there. And therefore it is very important. Express milk me for first 6, we'll have to insist. Please go for the now demand feeding. I have seen this some educated mothers that 2 hourly, that means she will be waiting for 6 o'clock. I think that is also the very bad or not necessary. And imparting the skill of the breastfeeding to mother and family members is very, very important. And I think with this reference, friends, I would like to remind this August gathering that our own government of India has given us the Rashtriya Bal Swasthya, this Karyakram. And that is the journey of the first 1,000 days, which is the foundation for a bright future of the baby. I think this 1,000 days of the nutrition, how it is playing the role in the development of this development of the child, they have imparted very nicely. That starting from this conception to even the first 2 years of life, how much it is important for proper nutrition. And if you provide this nutrition, it makes difference in the development of the baby. And by chance, if you fail it, many times you know that in our community, in our country, this is very common problem. And that's why we are facing so many issues that we should keep in mind. I think clothing point of view, bedding in and KMC is very important, which I talked. Wrapping the baby is very important, including, please, in the particularly winter season, cap, socks, and the blanket. But they should be loose and comfortable, not very tight, sometimes creating the problem with the respiration. Cord care, all of you know, friends, now we'll have to change our mind. Dry cord care is very important. No application of any medicine.
Sorry for interruption, sir. Just regulation of the time limit, sir.
Yes, yes, a minute only. All of you know that the length of the stem should not be very long so that it can be soiled. And after this fall of the cord, watch for the umbilical sepsis. I think bathing is not required. Don't remove the vernix. Bathing, you may go for after 7 days. Daily, it is not necessary. Your room should be warm. Soap, probably not necessary. Washing these particular groin, genitals, buttocks, very important and should be dried immediately. I think routinely any eye drops are not necessary at all. All of us know that the proper stooling and urination, we'll have to keep that it is going on. And lot many applications of the cosmetics is not required at all. Massaging, okay. I think coconut oil is best. Other things you may not go. No kajal on the eyes and no eye drops in nostrils or ears. The common concerns of the parents will have to understand regarding regurgitation, jaundice, some skin problems, diaper rashes, oral thrust, breast enlargement, discharge due to the maternal hormones, and vaginal discharge, which is not important. These danger signs will have to explain to the mother, particularly distress, refusal of feeds, cold extremities or fever, and some eye discharge. Even convulsions, seizures or fits, jaundice is very important, pallor is important, bleeding, vomiting, particularly the bilious, as I talked, distension of abdomen, not passing urine on stool. We have to explain to the mother, taking some time, regarding the covering and prevention of hypothermia, exclusive breastfeeding for 6 months and up to 2 years, no bottle feeding, good hygiene, nothing should be applied over all these different parts, including the BCG. Regular follow-up is very important, friends, for growth, development, immunization, and to report immediately by chance child develops any of the danger signs. I'm sure that if we are taking the care of the postnatal period, it makes difference in our bringing down this neonatal mortality rate and as a whole infant and mother mortality rate. Thank you very much. Sorry for extending some time or some minutes. Again, thank you very much to the chairperson and Dr. Gargi. Thanks a lot.
Thank you very much, sir. Thank you very much for that wonderful talk. You mentioned and lot of take-home messages and simple methods that we have to follow and cautions that we have to follow, and particularly in the very few hours of delivery or early neonatal period. So, moving on to the next session, that's a very important session, that is breastfeeding. To deliver the talk, we have a wonderful speaker, Dr. Upendra Kinjabadekar.
You have to unmute yourself, sir. Doctor. Again, you are muted, sir.
Sir, please, Dr. Chilapati. Yes, sir.
Yeah. I think I did twice. I don't know why. Yeah, sorry for that. Straight away we'll go for the last talk of today, that is breastfeeding. To give the talk, we have Dr. Upendra Kinjabadekar. He is the senior consultant at pediatrician with over 29 years of clinical practice, affiliated to Kamlesh Mother and Child Hospital, Nerul, and also is working at Apollo Hospitals, Navi Mumbai. He has got 15 publications in textbooks and journals, has authored many IAP modules, and his special area of interest is infectious diseases, pediatric nutrition, vaccinology, and pulmonology. And he was a honorary treasurer to IAP, Central IAP 2018-19. Over to you, sir.
Yeah, good evening, everybody. Thank you very much, Dr. Venkatachalapati, for that kind introduction. And let me thank Dr. Gargi Patel, Dr. Chuhi, and of course, the teacher of teachers, Dr. Baldev Prajapati, sir, for giving this opportunity to talk to this August gathering. And my congratulations to all the team members of IMA for last 5 days, a wonderful program, which is, though virtual, but then attended by so many people and really enlightening everybody on the important aspect of safe motherhood. So great job by all of you. And this is the last talk. I know that everybody must be a little bit tired, but then most important, they have kept it at last. So breastfeeding, without that, you cannot just complete the talk of safe motherhood. The most important of all, and we have to do, I have been given only 15 minutes to speak about it. I'm trying to justify these 15 minutes and try to give the important messages in these 15 minutes as much as possible. Let me start off with a very important recommendation of every health organization across the world, from IAP, AAP, WHO, the Baby Friendly Health Initiative, anybody. They talk of exclusive breastfeeding in first 6 months and continued breastfeeding for 2 years and beyond. So extremely important to know that every baby should get only breastfeeding for first 6 months and continue breastfeed and add on complementary feed. That should be nutritionally adequate, safe after the infant reaches 6 months. So one should not stop breastfeeding. So that's why the word weaning is given up from our pediatric dictionary and we call it as complementary. So it is just complementary whatever breastfeeding is doing, because breastfeeding continues to give proper nourishment to the baby even after 6 months of age. But let me start off with an alarming slide. Look at this NFHS 4 data. though it is little old, 15, 16, early initiation of breastfeeding in my country, friends, is only 41.6%. On the right side, the figures which I share are from Maharashtra. We know that the all India figures are not yet out. In August 2020, we had these figures for a couple of states. Maharashtra has 53%, meaning that 47% of the babies delivered in our country do not get breastfeeding in first 1 hour of birth. That is the most important point. And if at the end of my lecture, if these 300, 400 odd people go and tell it to 10 more and 3,000 and 3 lakh, and within a year, this figure changes to 93%, will be the happiest person. Exclusive breastfeeding. We've talked about so much. I thought India must be leading. But look at it, 55% it was in 15, 16. In Maharashtra, it has gone to 71%. I'm happy, but why not more than 90%? And introduction of appropriate complementary feeding 6 months is only 42%. And the 9% figure I've shown on the right, the variety of food which is important is given only to 9%. So we have to work so much, literally pull our socks up and talk to these patients, the families, that they have to ensure that the baby not only gets breastfeeding, but also good complementary feeding. A little bit of theory is extremely important to know that lactogenesis, that is the synthetic capacity of the mammary glands, that is in utero. It is not under your and mine control, completely under endocrine control. It starts off in 16 to 20 weeks. But lactogenesis too. So every obstetrician, neonatologist, pediatrician, and general physician, please pay attention to only this part, that 3 to 5 days postpartum is make or break slides. So please ensure have copious milk production. One has to see that the baby suckles frequently at breast. Lactogenesis 3 is maintenance of mature milk. There is some disturbance. Can you mute others? Can the host do that, please? Thank you. Thank you. Thank you very much. So the lactogenesis 3 is the last part, maintenance of mature milk, which is a local under autocrine control. So we talk about lactation failure so easily. I see, I'm really pained to see that people give tins of market food for the babies born because cesarean section hai, chati ko kaise lagaye, doodh aata nahi hai. These are all misconceptions. We have to work on that. Actual delayed lactogenesis is 15% and failed lactogenesis is only 5%. So more than 95% of chance that you and I, if we work together, baby will ensure to have good breast milk and babies will get good breast milk. So given early opportunities, some assistance, some correct technique, every mother will be able to successfully establish breastfeeding. So lactation insufficient, friends, is a perceived problem. Am I producing enough milk is a common problem for every mother. And look at the reasons. So these are many reasons. The obstetricians are really doing their best to take care of everything. But the most important of all is delayed first breastfeeding. Now, tell me honestly, all those who are attending deliveries, do you ensure that first meconium, you ensure about first urine, you ensure about first cry, but why don't you ensure about first breastfeeding in front of you? The normal delivery which has happened, cried immediately put that baby, and baby, the breast crawl will happen and baby will establish nice breastfeeding, placenta will separate fast. So please don't miss that 1 hour. So you have to instruct the staff under you that every baby born in our care, under our care, in our setup has to be breastfed in first hour. That is very important. So failed lactogenesis is actually so rare. 95% of the times it is not at all there. And these are some rare causes. Let's not get into the detailed causes because they are not important. Now, we have liver function test, we have renal function test, we have pancreatic function test, but do we have breast function test? No. Breast is the only organ in the body that does not have a diagnostic test to measure. So it is the perception. So that is where we have to work, and then the art and science of counseling comes into that. So delay should not happen in lactogenesis stage 2. Time and again, I'm just emphasizing on that part. So there are technically some test weights and biochemical markers, but what we do in clinical practice, whether the baby is successfully breastfeeding or not, it is just infant weight loss less more than 10%, less than 6 wet diapers by day 4, delayed bowel movements or continued meconium, no audible swallowing, signs of dehydration, the baby is irritable, restless, no changes for 5 days after delivery, persistently increasingly painful nipples, intolerable pain, then these are the places wherein we feel that there is definitely some delayed lactogenesis. So we have to ensure that if it doesn't have to happen, early and successful breastfeeding should happen very early after delivery. So what should I do? Earlier effective suckling, enhanced maternal infant bonding. Why do you want to keep baby just because the LACS in nursery? That is not an indication. That is not an indication to start cefotaxime. So immediately, even after LACS, baby can breastfeed in 1 hour and baby can be kept with mother. So improved neonatal temperature control will happen, longer duration will happen. Do not separate these babies just because there's some high risk or VIP patients. In fact, they should be with the mother. Identify and eliminate the causative factors, local problems, nipple problems, improper attachment. These are small technical problems. Look at the poor primey. Now, yesterday in my hospital, I saw a mother who was 19-year-old. I said, how could this son, such a young girl who has become mother, she was so anxious to know everything about breastfeeding. So we have to give some time. Otherwise, a wrong feeding practice will set in and it will be difficult to overcome once we discharge these babies. So reinforce, build their confidence, ensure frequent and effective suckling. And this is the most important part, that the baby should be, even the body of the baby should be with the mother's abdomen, chin touching the breast, lower lip curved outside, mouth wide open, lower lip covers more portion, but some portion of areola should be visible on the top. So a latch, once it is established, take time in that, but then baby will immediately ensure that he's feeding well. So supply and demand principle. So as Dr. Baldev Prajapati sir said, it is not too hourly, as much as you want, no restriction on frequency, no restriction on length. More suckling, more milk. Such a simple physiology. We must help mothers to do that. Now, I'm just lastly going to take one single case and 4 different scenarios which are common in everybody's practice, and how can we overcome by doing some little bit of counseling. Look at this term baby who was 2.9 kg, kept in recovery room for 1 hour. Mother was kept. Baby weighed, vitamin K given, perfect. Both mother and baby shifted to the rooms. Very good, very early. Mother is under sedation naturally. Baby is sleepy. But grandmother complains, Doctor Saab, bachche ko maa ko doodh nahi aa raha, baby is not feeding well. So the nurse notices granny is feeding honey. So prelactal feeds they should be encouraged? No, not at all. They replace colostrum. They are more likely to develop infections, the babies who are fed prelactal feeds. Intolerance and allergy will come in. Proteins in the artificial feeds, the allergies, eczema can set in. Interferes with suckling. Hunger is satisfied, the baby will not breastfeed. And then if he's fed him from bottle, then different problems, difficult attaching later to the natural nipple confusion, suckling confusion. It's entirely different ball game when the baby is feeding through bottle. A strict no should be the policy. And breast milk takes longer time. So look at the problems with a simple thing. What that granny was doing was giving a honey. So we have to be very, very vigilant. Our staff, even the IMA houses are important. Not only your nurses and doctors can't do everything, but these people should be like a, Hawkeye. They should be monitoring these mothers. Now look at this. You have convinced that no prelactal feeds. The second problem of the same case. Now granny is convinced, okay, Doctor Sahab, hum nahi denge honey. But then baby is not latching well. Now mother is anxious. So latching, how to ensure good latch. So this latch itself has an acronym, and there is a wonderful mnemonic. Look at C. L stands for latch, which should be grasping the breast as I showed you earlier, and it should be rhythmic suckling. There should be audible swallowing. A stands for that. T is type of nipple. So inverted nipple is the best, but even an inverted or a flat nipple is not at all a problem. Comfort. It is a painless procedure. Mother should not be in pain. Baby should not be in discomfort while sucking. So soft, non-tender breast. And hold. So there should not be every time sasuma, ma, granny, dadi, nani, staff nurses, nahi idhar pakado, udhar pakado. Mother should be able to position. So LATCH ke har point pe agar hum gaur karenge, I'm sure we can see that every mother is able to successfully breastfeed. So this latch score, friends, please take a printout and put it in your labor room. In fact, every room where the mother and baby are there, and ensure that everybody does this and ensures that the breastfeeding is given in first 1 hour after birth. Now, how often is another question. So as we said, it is not military ki 7 baje nasta milega, 10 baje ya 1 baje aapko lunch milega, 7 baje raat ko dinner milega. No. There is nothing scheduled feeding. So baby will have hunger cues. Now this is very important. Crying is not at all important. It is the early cues. Baby will start doing stirring, mouth opening, turning head. These are the cues which mother should recognize and immediately start feeding. इतना ही में नहीं काम हुआ तो then baby will start doing stretching, physical movements, hand to mouth. Or abhi bhi, if you don't offer breast, this baby will start crying, get agitated, turning red, and then you have lost the battle. It's a very difficult game when the baby is really agitated and then trying to put him to the nipple. So tell every mother that SMT is very important. Stirring, mouth opening and turning head is the earliest clue, and please feed the baby immediately. So remember, crying is the last expression of hunger, and we do not want baby to cry for it's a natural birthright. And then the last question comes is, Doctor Saab, kuch doodh badhane ke liye dawa de dijiye. Is there any role of galactose? If you ask me, water is the best one, 1.5 to liters, and there are evidence based. ये statement मैं ऐसे अपने दिमाग से नहीं बता रहा हूँ कि पानी is so important. It's a placebo effect if the galactose, even if we give it. It instills hope and confidence, capitalize. And I know that we have haliv and garlic and so many other things, methi, that people do give. अरे देने दो, उसपे कुछ नुकसान तो नहीं है. But if they give this feed, ensure to that other balanced diet is also there, not at the cost of that, let mother have it. But capitalize on prolactin and oxytocin reflex. So you remember that prolactin is secreted after the feed to produce the next feed. So that's why it is important. And there is more secretion in the night. So never ever stop the night feeding. So that is how we should help the physiology to help us. This is the way it should go. And oxytocin also. But before prolactin, let us see that it can be enhanced. How often and how long the baby is suckled, how strongly, produced after each feed, secreted more during night should be remembered. And if we give prelactal feeds, if we make baby wait for feeds, dummies, pacifiers are used, certain medications for mothers or painful breast condition, then it will be inhibited. So this is the way one should remember the physiology and help the mother. And finally, oxytocin. This is the love hormone. So loving thought of the baby. In fact, you know that mother is in different room, but the cry in different room. Mother just remembers the baby and the milk starts coming out. Sound, thought, crying, and then confidence and KMC also known to help mother secrete more breast milk. But then if this mother is stressed out, she is worried, she has pain which you have not taken care of, she has doubt about herself, her feeding technique, the lactation, and she's separated from baby, then you will have problems in successfully establishing breastfeeding. So if we take care of all that, so friends, my last slide, I would say that oxytocin also contracts, of course, this is the early part, that PPH, but laid down of milk from one breast while she feeding another, and she can very well store and keep it for 4 to 6 hours in outside temperature and refrigerate it for 24 hours. All this is proven to be of use, even if for working mother. So there is no excuse for not breastfeeding, very important to remember. So the biggest challenge, the theory is known, the knowledge is known, why it is not getting converted into practice. How many of you keep your hand on your heart and say that you do not prescribe a tin in the hospital when the baby is just because LACS, ek din, do din ho gaya, doodh nahi aaya, iske liye humne chalu kar diya. No, naturally it will be third day. And as Dr. Baldev Prajapati sir said, colostrum is good enough in a first day. Whatever mother produces is enough for that baby. But then 2 to 5 days you take enough care. But afterwards, then you have to help the mothers to ensure that she gives absolute affection. There is a program called Mother's Absolute Affection. We have to create awareness in community, in health facility, monitor breastfeeding. So do not be in a hurry to discharge these babies. I like this article in Hindustan Times, which said, no discharge from hospital if woman is unable to breastfeed after delivery. So, baad mein aake dikhao is a wrong thing. Keep the baby for 1 more day in the hospital if you are not sure about it. Ensure that you have addressed every problem. And I'm sure this baby is going to go home, have exclusive breastfeeding for 6 months, and will be a happy child and also the mother. So that is what is the important. So remember that Stanpan, ye vikalpa nahi, it's not a choice, but it's a sankalpa. It is a birthright of the baby. And you and I, as healthcare providers, have this tremendous responsibility to change the figures to 100% exclusive breastfeeding by the time our next NFHS data is out. Thank you very much for your patient hearing.
Thank you very much, Dr. Upendra Hinjwadekar, sir, because that was a wonderful talk, and you stressed upon the need for early breastfeeding and the advantages of early breastfeeding, and try to avoid all the prelactal feeds and encourage the mother to breastfeed. So I think we've come to the end of the session. And I think the house is open for any questions. If there are any questions, I think the house is open for questions.
From Dr. Virendra Pratap Maurya, who wants to know, sir, should we apply betadine on cord or not?
Not at all. There is no need unless there is some sign of inflammation or sepsis. Routinely application of any antibiotic cream or any is not required.
And there is a question in the chat box stating that how to address the maternal exhaustion. Because in the first hour or so, there will be maternal exhaustion. How to address that, and if you say that we have to feed at the first hour. Dr. Upendra?
Yeah. Sorry, my connection was lost. Can you just please repeat the question?
Yeah, how to address the maternal exhaustion? Because the first hour, the mother would be definitely exhausted after the labor pains and other things.
Exactly. So in fact, after first hour, the mother gets exhausted. During the process of delivery, once the baby is out, mother is extremely happy. She's relieved. So immediately the baby comes out, makes entry in the world and put on the abdomen, in fact chest, in bit, and then baby immediately starts suckling. So that is the time the baby is also alert, mother is also happy, and immediately the placenta also separates. But if you lose this first 1 hour, later on the baby also goes to sleep, mother is also under some sedation, and then you lose that precious 1 hour. So it is extremely important to utilize that first 60 minutes. So that's why it's a golden hour, golden minute for crying and golden hour for feeding. Please, irrespective of the method of delivery, ensure that every baby gets breastfeeding in first 60 minutes.
How to treat cracked nipples? Will apply nipple guards effects on milk production?
Yeah, so no, we do not recommend that. So in fact, there is a fore milk, the mid milk and the hind milk. Even if the hind milk is put on the cracked nipple, that is found to be excellent as far as healing properties are concerned, because it is full of fat. So if mother can do that and take care of. Actually, cracked nipple is because of faulty technique, poor latch. The baby bites on the nipple and that's why it is happening. So baby should not bite. Actually, nipple is nothing. It is the areola, which is very important. So nipple is just the tap from where the water comes. So milk comes from that. So nothing comes from nipple. It is the areola that baby has to latch on to, suck properly, and the milk flow will be ensured, and mother will not have any problem in the nipple.
I think, may I just respond?
Please, sir.
I think just to convince the persons that mother is never exhausted. All of us know that if you are interested in your dear ones, the person is never exhausted. And all of us must have experience. Even I have seen my residents that after the COVID duty, running very fast and going to meet her, I would say his fiancée. And he's never exhausted even after the COVID duty. And I'm sure that no mother is exhausted at any time.
Breastfeeding in cancer patients on chemotherapy.
Yeah, so these are sometimes a difficult, challenging situation, and certain medications, yes, there is a contraindication, but it is very few medications which are responsible for, it will be passed on through the breast milk. So it's an exception to the rule, but otherwise, most of the other medications, baby can successfully latch onto the nipple and latch onto the areola and take the breastfeeding.
Now I would request Chalapati sir to conclude the day.
Thank you very much, Dr. Upendra Kinjwadekar sir, for the wonderfully answering all the questions, and it was really enlightening. I take this opportunity to thank one and all, and particularly all the speakers who brought out very nice information, and it was very simple, and it was very much required during our day-to-day practice for all the people who are practicing who are in care of mother and child particularly, antenatal, intranatal, and postnatal science. So I conclude this session today, and I once again thank the organizers for giving me this opportunity. Thank you one and all, and good night.
Thank you, everybody.
Thank you.
Thank you.
Thank you.
Thank you, all the speakers. It was a wonderful, wonderful session, and I am very sure that it is so important for all the mothers to know all these things, because what happens is she has so many questions, and then they call frantically, try to call the pediatrician every 1 hour. So I really want to, as Sir said, share these recordings to all state branches, make them converted into local languages of each state, and make it reach to every center, every PHC, so that they know the answers to all these doubts that they have postpartum. That is something that I would really, it would make me happy if we can make it reach all the way till the grassroots level. So thank you so much. And thank you, Dr. Juhi and Dr. Gargi Patel, for an excellent session today. Thank you.
Thank you.
Good
Thank
night,
you,
everybody.
everyone.
Thank you, Gargi Madam and Dr. Juhi.
Thank you all.
Thank you and good night.
Thank you, Dr. Gargi, Dr. Venkatachalapati, Dr. Juhi, Baldev Prajapati, sir.
Thank you, sir.
Dr. Datta, sir, thank you, sir, for being there, sir.
No, thank you very much. And only one thing I have to, because it is too late, there is no question of discussion. We as a gynecologist is very much worried about the cerebral palsy. Now, if there are any, we will discuss that because no time is there. That is the problem. But we are very much concerned when the antenatal clinic, mother always asks to us, can we prevent the cerebral palsy? Can you prevent the Down syndrome? Can you prevent I am suffering from the thyroid disease, hypothyroidism. Can my baby be the hypothyroidism? How you know it? So there is many questions come because the time is not there. Another they will discuss all these things. But the problem here, excellent presentation. I think that our team, Safe Mother, we are always safe. And I hope so. Under the leadership of our total team and Erica, we can prevent everything in the future. Because today's discussion is a totally neonatal, prevention of neonatal morbidity and mortality, along with the maternal. This is good. Thank you very much. Good night to all. And
thank you, Dr. Jailal, sir. Sir, thank you for being here, sir.
Thank you, everyone. Thank you.
Thank you.
Gargi Madam, I'm so happy to hear your enthusiasm and
Thank you very much, sir, for giving me this opportunity. Actually, sir, there's a request from Ujjwal Kumar Sengupta from IMA Bengal State, but we are too late to. He requested to Dr. Dilip Kumar Datta, sir, to give a rejoinder about the MMR, because sir has so many publications, but it is too late. He says we can take on the list because there are so many requests.
I'll talk later on. Only I have to tell the Joylal sir, his vision to reduce the MMR before December, this December, before his ending.
Yes.
I promise sir, even then the government of India cannot reduce till today 130 per 1 lakh maternal mortality. But we will try definitely, sir. And I hope so. Under our leadership, we'll go to the rural area, prevent the maternal death in the rural area, other than urban area. So I will do definitely, sir, for you and my team. Thank you very much, sir.
Thank you.
Thank you very much, sir.
Good.